Hello everybody, welcome to my YouTube channel, and today we will talk about an important aspect of surgical critical care, which is called ERAS, or Enhanced Recovery After Surgery, the concept and the new trends. I have been asked to talk about this in a recent conference called TechCon 2022 in Hyderabad, and I thought to share this study material with you all. So ERAS, or Enhanced Recovery After Surgery, it's a multimodal, multidisciplinary approach for care of surgical patients. This is a structured implementation program that has been currently running in more than 20 countries. And the target is to reduce the stress of the operation and to retain anabolic homeostasis related in the postoperative period. The main goal of all those interventions are to promote early recovery. And eventually, it has shown to improve in the patient's outcome in terms of shorter length of hospital stay with reduced complication, reduced readmissions, and overall decrease in the cost. If you go back and look at the history or journey of ERAS, it was initially addressed in 1994 by cardiothoracic surgeons when they used to call it as a fast-track surgery. And they tried to implement a bundled perioperative management in their CABG patients. But eventually, they found it little inappropriate, basically ethically, because they feel that the key surgical endpoint should be the quality rather than the speed of recovery. And subsequently, this concept has been picked up by colorectal surgeon, and they implemented it in their practice for the sigmoid resection. And they have shown that it causes substantial shortening of the recovery time in their subgroup of patients. And gradually with time, a group of academic surgeons was developed in Europe around by the year 2000, 2001, and they promote ERAS practice and call the ERAS study group. And they believe that the overall perioperative care rather than the actual operation dictates the patient's outcome. Now, if you look at the journey of a patient from admission to discharge, specifically surgical patients, they usually come first to the outpatient clinic, followed by preoperative unit for preoperative evaluation and optimization, operating room, and then to the postoperative recovery facility. The surgical team usually involved from the day one because it's coming to their OPD. After that, probably the anesthesiologists were most closely related to the patient care. And the target is to make this journey of this patient smooth, along with decreasing the hospital stay. So the ERAS team consists of surgeon, anesthesiologist, along with them may be intensivist, nurses, dietitian, physiotherapist or occupational therapist, ERAS coordinator, and social worker. So this is a multidisciplinary approach to improve the patient's care. And it has been shown in the studies that the importance of collaboration, communication, and thorough staff education for ease of the program implementation has shown better success rate with ERAS. What are the scopes? Most of the data is related to colorectal surgery. But the similar principle has also been implemented in other surgeries like liver resection, pancreatic, gastric, and esophageal surgery, thoracic surgery, major urological surgery, gynecological surgery, orthopedic surgery, and also in emergency surgeries. What are the objectives? Objective is to preoperative optimization of the patient and decrease in the perioperative stress. And as a result, the target is to maintain postoperative physiological function and try to accelerate the recovery time after surgery. And during this journey, by maintaining homeostasis, the patient avoids catabolism with consequent loss of protein, muscle strength, and cellular dysfunction. Also, as there is a decrease in the insulin resistance, it promotes adequate cellular function during injury to the tissue. If you look at the components of ERAS, it starts from pre-admission, followed by preoperative, intraoperative, and postoperative period. Though our focus is on the postoperative ERAS components and its ease of implementation and the compliance, but still there are factors in the pre-admission, pre-op, and intra period which can significantly influence the post-op outcome of these patients. So we'll briefly go through them. So in pre-admission, the most important is cessation of smoking and excessive intake of alcohol, because along with physiological component, there are psychological components also. And if they continues to smoke and drink alcohol till the surgery, there is significant risk of withdrawal in the immediate post-operative period. Along with that, preoperative nutritional screening and as needed assessment of the assessment, detailed assessment, and also optimal nutritional support. And also, we have to medically optimize the chronic disease or comorbidities of those patients before admission. And in this regard, a very important concept is education of the patient and his family regarding their journey to the during this surgical period and what they can expect in the preoperative, intra, and post-op period. With better education to the family and the patient, the compliance of those patients with all those intervention improves and the chance of outcome is better. In the preoperative components are structured preoperative information and engagement of the patient and relatives to the caregiver if had not has been done already. Preoperative carbohydrate loading, it's shown that it reduces insulin resistance, improve well-being of the patient, and possibility of faster recovery. Preoperative prophylaxis against thrombosis decreases the thrombotic complication, and preoperative prophylaxis against infection that usually we give just before the surgery that reduces the perioperative infection rate. But it is not exactly a preoperative prophylaxis, it's basically an intraoperative prophylaxis. And also prophylaxis against nausea and vomiting. During the intraoperative period, there are some challenges or the standards from the surgical team and also some interventions from the anesthesiology team. So surgical teams like minimum invasive surgical technique, from anesthesia, standard anesthesia, avoiding long-acting opioids, maintaining fluid balance to avoid over or underhydration, epidural anesthesia for open surgery, restricted use of surgical drains from the surgical site, removal of the nasogastric tube before reversal of anesthesia, and better control or optimal control of the body temperature using a warm air blue blanket or warm intravenous infusion, depending on the availability. And now we come to the post-operative, which is our main target today. So important components are early mobilization. It supports normal movement, return of normal movement, early intake of oral fluids and solids, early removal of urinary catheter, intravenous fluids once the patient start taking oral adequately. Mostly it is done on the day after surgery. Use of chewing gum and laxative and the peripheral opioid blocker agents sometimes return the gut function, but though the data is not very strong. Intake of protein and energy-rich nutritional supplement. It increases energy and protein intake, leading an addition to the normal food. Multimodal approach for opioid-sparing pain and control. It is very, very important because pain control is related to physiotherapy and prevention of complications like pneumonia. Multimodal approach to control nausea and vomiting. Prepare for early discharge and audit to outcome on the process of multi-professional, multidisciplinary team on a regular basis to look at the compliance related to it. Now, what is the outcome? It has been shown in studies that it decreases length of stay. The complication rates are reduced up to 50%, specifically in colorectal surgeries. Better the compliance of the protocol and better is the outcome. So it goes with hand by hand. There is a reduced rate of reoperation or admission to the intensive care unit, including mortality. And obviously, if the patient's outcome improves, there is a significant saving of the cost to the patient. And also because the turnover increases, it's also profitable to the hospital. Along with short-term outcome, there are also long-term and medium-term data to show better outcome. Like there's a 2-year mortality has shown to be decreased in orthopedics and colorectal surgery. But there are some challenges with post-operative areas. Because there are significant lack in compliance is one of the multidisciplinary phase of care, because you can see in so many specialties are involved to provide service. Large multicenter study, more than 400 patients undergoing in the colorectal subgroup of patients has shown there is a significant variation from protocol in the postoperative period. For an example, that nearly 50% of those patients has an nasogastric tube left in the postoperative period. So the awareness, understanding, and knowledge related to the ERAS concept and also the anticipated outcome in terms of patient improvement need to be disseminated among the caregivers in the perioperative team. Next week, we'll discuss few about fluid management. This is a very important concept and we most of be aware of it. We know there's a concept called U-shaped distribution and also in critical care, also in perioperative period, where if you give less fluid compared to the optimal, there will be hypoperfusion, organ dysfunction, and adverse outcome. On the other hand, if you give more fluid, there will be tissue edema, and eventually organ dysfunction and adverse outcome. So the target is to give optimal fluid, and it's shown that improving fluid management lead to a decrease in complication, decrease in length of stay, and enhance patient outcome. Presently, what we are practicing is called goal-directed therapy. We try to optimize tissue perfusion, and in this regard, we monitor certain indicators, maybe in terms of cardiac output or stroke volume, to improve the blood flow to the tissue. And it has been shown that early transition to oral hydration is better in terms of healing and recovery from surgery. At the same time, we can cut down or decrease the IV fluid. In the immediate postoperative period, even though patients are not able to take orally, you can start with IV fluid in a restricted manner, maybe 1 milligram per kg per hour. And once the patient is able to take feed, which should significantly decrease the IV fluid, and try to stop it to the earliest. And as I already mentioned, there are multiple concepts of fluid therapy, like liberal fluid therapy that has been obsolete. Restricted fluid therapy is shown to have a poor outcome in terms of organ dysfunction, specifically kidney. Zero fluid balance, which has not been popularized, but the most commonly practiced concept is called goal-directed fluid therapy. That means if there is an evidence of tissue hypoperfusion, only then we'll increase the IV fluid in beyond maintenance. Pain management, another very important concept. Along with opioids, presently we are moving more towards neuraxial anesthesia, anatomical anesthesial block. It has shown that it decreases the narcotic use significantly, less pain at rest and on movement up to 72 hours postoperatively, and it eventually prevents the central sensitization and subsequent development of chronic pain. And also, opioid has a potential for tumor growth and metastasis. So also the use of opioid has been targeted to decrease or in coming days. So basically, what we are practicing is called multimodal narcotic-sparing pain control, along with minimum dose of opioids. We try to use NSAIDs, acetaminophen, gabapentin, regional and neuraxial anesthesia, intravenous ketamine, and lignocaine infusion. Early feeding is a very important concept. Target is to start into nutrition early in the postoperative period within 24 hours, and it shows that there is a decrease in the mortality without any harm related to the anastomotically. And in patients who are malnourished, nutritional support may need to continue for at least 4 weeks in the postoperative period. Protein has been identified as a very important component of nutritional supplement. It shows that with increasing protein intake, the anabolic metabolism improves, which is needed in post-surgical recovery. And patients who are receiving high protein diet, that is more than 60% of the daily protein requirement in the postoperative days 0 to 3, are found to have a reduced length of hospital stay and better outcome. And along with that, if we are using preoperative hydration with a complex carbohydrate, as I already mentioned, up to 2 hours before surgery, it improves metabolism, decrease insulin resistance, decrease anxiety, and there's a reduce in the nausea and vomiting. So it should be promoted. There are also some soft data related to immunonutrition, which includes arginine, glutamine, omega-3 fatty acid, and ribonucleic acid. It has shown to influence our nutritional state of the body and also the immune system in a different way. So the data is not very robust, but physiologically these are logical to use. Like it can modulate the immune system, regulate inflammatory response, protect against ischemia and reperfusion injury, promote T cell maturation, increase nitrogen balance and lipid metabolism, and also supply energy to the gut mucosa. By this, there's maybe some outcome related improvement, but physiologically it looks good. Glycemic control does not need any special emphasis. It's very important perioperative period. We know that fasting leads to catabolic metabolic state, and in this patient, if the patient is fasting for a longer duration, it reduces liver glycogen store as well as increase insulin resistance and postoperative stress. This will be more prevalent or more important in diabetic patients. And at the same time, postoperative hyperglycemia has shown to increase morbidity in terms of infection, neuropathy, renal failure, and mortality in certain extent also. So optimal glycemic control is very, very important component in perioperative period. Tubes and drains I already mentioned. You should remove it as early as possible. You should not put it if it is not necessary. And it has shown that in terms of pelvic and peritoneal drain, it did not decrease anastomotic leakage, wound infection, and reoperation rate and mortality. So even in a rectal surgery, it should not be used routinely. In terms of orogastric tube, there is an increased chance of pharyngolaryngitis and respiratory infection, with use of orogastric tube, so it should be removed early. And it also shown orogastric tube removal helps in earlier return of bowel function and decrease in pulmonary complication, as already mentioned, without increase in patient morbidity and mortality. It also beneficial or helpful for early nutrition of the patient, and there is no significant difference in anastomotic dehiscence, pneumonia, wound infection, rate of nasogastric tube insertion, and nausea, vomiting, or mortality. So presently, the usage of tubes and drains in peri-surgical period should be optimal as per the patient requirement. It should not be routine practice. Early mobilization, very, very important. And for that, we need to educate the patient, and patient encouragement is very important. It should be started in the preoperative period. It has shown that prolonged bed rest, there is an increased risk of developing pulmonary complication as high as 3 times, decreased skeletal muscle strength, thromboembolic complications, and insulin resistance. So there are units which practice goal-directed early mobilization, and it has shown to be associated with shorter duration of surgical intensive care stay and better functional mobility at discharge. And it has significantly associated with a successful outcome in ERAS. But at the same time, if there is a failure of early mobilization, rather than pushing for mobilization, we should try to look at the cause. What is the cause of early mobilization? Is lack of patient education? It can be lack of patient education, patient motivation, then will be pain, then will be multiple tubes and drains, which make the patient uncomfortable for physiotherapy. Those things we have to identify and address concurrently to have a better outcome. Now, as I mentioned, strongest data is for colorectal surgery. It has been shown that no gastric, the points I have mentioned, no gastric drainage, multimodal anesthesia, thromboprophylaxis, optimal fluid, removal of urinary catheter, control hyperglycemia, nutrition, and mobilization. These all have a very strong data, strong evidence for usage in the perioperative period, specifically colorectal. They have also recommended no routine pelvic drain, and thromboprophylaxis should be used mechanical along with pharmacological till the patient is discharged in rolling patient, and sometimes it is needed for up to 28 days as extended prophylaxis for colorectal surgery. Also, when this same concept is used in extensive GI surgeries, other gastrointestinal and pancreatic surgeries, it has shown to decrease length of hospital stay, decrease cost, but there is a significant risk of bias in this data. This very soft data, we need more data. So in terms of outcome analysis and research, there is a society called ERAS Society. There's a structured system to audit for ERAS protocol in all phases of the surgery. And we need more data specifically in the post-operative period to optimize our post-operative management. So what is the future? Again, more structured data is needed for post-operative period. And in this regard, to improve the compliance and usage of this protocol, we need to have collaborative work with other parallel professional societies like Society of American Gastroenterology, Endoscopic Surgeon, and ERAS or ERAS in USA. And maybe in India, we need to work closely associated with the Society of GI Surgery or colorectal surgery or other specialty surgeries so that they understand the importance of this intervention in the postoperative period for better outcome and also to accept it in their practice. By this, I'd like to conclude my presentation. Thank you.